Morning everyone. My name is Chris Lambert. I'm a clinical lead on the exercise and lifestyle program in Swansea, and I'm doing a talk to you this morning about our journey really of trying to digitalise our lifestyle program. So I've been working on our lifestyle program in Swansea since 2017. So a little background, we run a pilot on 100 patients in 2017, and then we secured ongoing funding in 2019 for 1,000 patients, which we're due to start in 2020. Next slide, please. So ELP is our exercise and lifestyle program. And basically, this is a little about the journey of patients into the program. So we see these patients from referral via their GP or primary care practitioner. So if you look at the colourful chart on the left, the blue bubble is where they come in to have assessments. These patients will present to their GP with knee osteoarthritis or a query diagnosis of knee arthritis. They'll come in for assessment in the service, and we will offer them a combination based on the NICE guidelines for management of that knee osteoarthritis, which involves education about the condition, an 8-week diet and exercise package, which usually they have in traditionally in their local leisure centre, and they will collect outcomes along the way. So this is the traditional model that we piloted in 2017, but my talk today is a little bit about how we have evolved that model onto an online or digital format, and the process and pros and cons that I've encountered along the way. So in terms of PROMs, when the patients come into the service, we call that a baseline. So we collect PROMs at that point. The second time then we'll collect PROMs would be at month 3. So at that point they've completed the intervention. So the intervention is an 8-week diet and exercise program, as I said. So this is completed at week 8, and then we collect PROMs at week 12. We go on then to take longer term PROMs at month 6 and 12. So the PROMs we're collecting are Oxford Knee Score, which is the primary outcome. MSK Health, which is a bit more of a generic outcome for MSK conditions, and we take EQ as well to look at quality of life, and we measure their weight obviously, and then come up with the BMI from that. Next slide, please. So this is the traditional model prior to us looking at converting this onto a digital program. So as I said, it's a therapy-led clinical assessment service. So they come in, they see a physio or an advanced practitioner via a referral from GP or primary care. And we offer this combination treatment then, so this MDT approach of weight loss, exercise, education. So normally it's a face-to-face exam. We were collecting paper PROMs initially, and keeping a database of those, and then they would receive their intervention in their local leisure centre. So this is the traditional model that we were working with. So face-to-face consultation, paper PROMs, and intervention delivered face-to-face in the local leisure centre of the patient. Next slide, please. So why digital health? Well, really, our funding came through in 2020 for 1,000 patients. At the same time, we obviously went into the COVID pandemic, so we were forced into this really. We were due to open in March or April of this year, and we were looking at how we could open up this new lifestyle program amongst the current policies that were in place in the local health board because of COVID. So it was, I guess it was forced upon us a little bit, but it was also a great opportunity for us to look at what the appetite was really amongst patients, amongst service users, for the longer term. So we wanted to know really, was there demand for such digital services? We wanted to know, could we reduce unnecessary patient contacts? Could we manage diagnosis over a digital format, i.e. telephone? You know, was there other methods we could interact with our patients without the traditional hospital appointment system? Could we collect PROMs? Could we do PROMs, our CROMs, our clinical outcome measures? Could we do all of this remotely? Could we share patient material? So a big part of our program is education, educating the patient about their condition and how they can self-manage. Could we do this in a similar format without bringing patients into the hospital? And the last part of it was, could we offer the actual interventions, the actual exercise and diet element? Could that be offered without seeing patients face to face? So these are the challenges we were up against. Next slide, please. So I guess at this point as a team, and I've been very fortunate in my role to be supported by the value-based healthcare team in Swansea Bay throughout this process, all the way from a pilot to a current situation. And we sat down as a team and had a look at the whole pathway that we were dealing with our patients coming through, and where they ended up on that pathway. And we wanted to see how much of that we could convert into an online or digital pathway. So all the way from initial consultation, telephone, virtual assessments, these that weren't new really, there were things that were going on in other services. Primary care had been using virtual assessments a long time, so there was lots of bits going around that we could maybe pinch ideas from. In terms of outcomes, we had a look as a team at what was out there to collect outcomes, and we stumbled upon a outcome pathway or outcome system called ProMap, which seemed very apt and appropriate for what we were looking to deliver to our patients. And we also had to look at other measures and how we could offer the exercise element of it. So looking at your teams and virtual online platforms, how we could deliver some sort of intervention to patients. So basically we were looking at which bits, if we broke up our service currently, which bits could we convert to a digital program? Could we offer it from start to finish and offer an end-to-end digital program or not? Next slide, please. So this is the digital pathway we come up with after lots of meetings and chats about what was out there. So we implemented and did a bit of work with ProMap Health and used them as our digital prom collecting system. So this is a system where once you've registered your patients onto there, that you can also register your outcomes, your proms, and then that system will automate sending out the outcomes via email. So you need a patient's email address, you need to put in your timescales, your touch points with patients when you want to send them the outcomes, and it will automate and send them out and also nudge them. Now, what I liked about this system is it also had the facility to store content, so educative content, so I could build up a library of education material for patients and store it on the same system. So when patients required some education content, we could also pass that on to them via their email as well, which made our proms and some of our education literature completely digitalized at that point. So the next point was assessing patients, knowing if they're appropriate for an osteoarthritis lifestyle program or not. We needed to speak to them, we needed to do an assessment. So we tried the telephone exam option. So at this point, the whole pathway now is without face-to-face, so we could run it with during COVID policy guidelines. But what we did find at this point, one of our interventions, which is injections for patients, where we put a steroid injection into their knee if they're having high levels of pain and they're not able to control it with normal analgesics. It was impossible to deliver, obviously, over a telephone. We would have to bring our patients in if they did require an injection. So at this point, some of these options then required a face-to-face consultation. So going back to this diagram, patients were sent, this is our digital pathway we've created, patients were sent their proms before they had the assessment. So when the clinician phoned the patient up, they already had their proms, they had their Oxford knee score, potentially they had their knee x-ray because that's done by the GP. So they had a lot of information on the telephone to complete an examination. Now, at the end of the consult, the patient gets a choice whether they want to self-manage their condition and be passed on some information, some of our educative material. We've got some pre-recorded exercise videos. We've got some links to weight loss, and we could pass that on to them and the patient could independently self-manage. At that point, they wouldn't need to come in and see us. However, if they chose to have an injection, or they chose to come onto the online version of our class. So this would be where they have live classes of exercise and weight loss, which they register and come onto via Teams each week. They would need to come in for a further assessment because our exercise professionals would require an updated blood pressure score from them to make sure they are safe to engage in live exercise. So we managed to part digitalise the service, but then we realised that if a patient needed injection or they wanted to come online, so we needed to do some CROMs and blood pressure, then they needed to come in for appointments. So we were managing our self-management category of patients completely digitally, and then we were bringing our other group of patients who wanted online or an injection in for further assessment face-to-face. Next slide, please. So this brought up some early problems immediately for us, really, because what we noticed, and what is a theme throughout my talk really, is how we tried to use prompts and data that we were building up from what we were collecting off patients to try and improve the pathway for patients. But what we noticed was around, so if you look at this is the complete amount of patients that we saw at one point, around 300 patients on here, I think around 250 patients there. Around 50% of them we noticed were coming back in for either an injection, or they were required to go on to the online pathway. So they had to come in for a further assessment and have their blood pressure done. So what this meant was we were assessing all of the patients on the telephone to start with, but half of them were having to come back in for a face-to-face consultation, either for an injection or, as I said, for online exercise tests, basically, to make sure they're safe. So we were actually double handling these patients. So it caused a big problem initially in the service because we didn't have allocation of these extra appointments. So, for example, 200 patients being seen would then create 300 appointments because half of those 200 were having to come in a second time for their injection. So it was doubling up on creating these multi-appointments of patients. So that was the first issue we came up with in our digital program, that some of the patients were actually requiring to come in the end. So we're having to offer them double appointments. Next slide, please. So I sort of summarised, and this is not something I did at the time, but this is something I've done retrospectively now, the pros and cons of where we were at with the different aspects of digitalising this service. So in the three separate parts, we've got tele-assessment, digital prom system and online classes. So these are the three main areas of my pathway for ELP, for the lifestyle, and these are the pros and positives and negatives in. So in the green for tele-assessment, which is the positive boxes, we've got it suited patients that were isolating because of COVID. Those were generally unwell or didn't feel happy or safe to come out to a hospital appointment. Those patients absolutely loved having a telephone assessment. And obviously it's a very green and very cost effective way of managing patients for the health board, because they can have their appointment in the luxury of their own home, possibly in work, via a telephone that is agreed within the hour slot. So a lot of positives there. The limitation was that these telephone exams were a little bit limited. It's quite difficult as a clinician to assess a knee without getting your hands on a knee, without being able to see it practically. We did have the option of flipping to video with one of the telephone systems we're using, but we often found our more elderly users potentially weren't as capable of using that technology on their end to share video, so we could have a look at their knees. So we were often found that we couldn't see the knees, we couldn't physically assess the knees, didn't have the luxury of watching the patients moving and coming into an appointment like we would in a hospital setting. And the patients felt that as well. I think this was their first chance to be seen in a more specialist clinic for their knee pain, and they had been spoken to by a GP on the phone potentially, and if we'd spoken to them also on the phone and assessed them, nobody'd assessed their knee, and they felt that they hadn't had their knee assessed properly. That was the feedback we were getting from patients. So that was the negative side of the telephone exams. In terms of the digital pathway, the ProMap system we used, the pros were we were finding compliance was pretty good. So when we were sending out these emails with the PROMs, the Oxford knee, the EQ, patient's weight, we were collecting all of this before they turned up for their first appointment. Compliance was around 70%. So we were pretty pleased with that. The automated reminders to nudge patients to complete them was working really well, and the capability to store a library of education content was brilliant for us. So there was lots of pros with this. Negatives from using a PROM system, a digitalized PROM system, was it didn't cater for those with no email. So that we soon found out that we had a group of patients that didn't have an email, and this was higher than I'd anticipated. That was a problem. Other issues with running such systems is there is cost elements to them, so you need to factor that into your business case if you're looking at setting up a service, and they need a lot of shaping, they need a lot of work. So you need a manager or clinical lead that's going to work with these companies, because they basically give you a blank canvas to set up to suit your and customize for your service. So it needs a lot of programming, a lot of meetings amongst clinicians or managers and the digital team, the technology team, really, to get the pro map or the PROM system working exactly how you want it. So there's a little bit of work, a bit of legwork involved in them. In terms of online delivery, again, similar benefits to the telephone assessment. Brilliant for those patients who are not happy to come into the leisure centre, who need to isolate, or not maybe in a situation where they want to go out into a community space. So excellent to have online classes at home, could do exercise in the luxury of own home via Teams. Again, very cost effective in terms of not having to book rooms or spaces in your leisure centres. The feedback we were getting though from our instructors delivering these exercise sessions it's pretty difficult to create a good group dynamic situation. So what I mean by that is we're trying to create a behaviour change in intervention when we bring patients in. We're trying to get them moving for the first time. They've often been told that maybe exercise is not good for their knee, so we're trying to create a behaviour change, and it's quite difficult to do that. And when you don't get a good rapport with patients, you need to create that sort of build in sort of relationships with them. Really, it's quite difficult to do that on a digital platform like Teams, and it was quite hard as well. Our patients were saying it was quite hard to give feedback, individual feedback. So what we all like to do as clinicians when we're teaching exercises is make sure patients are not in pain when they're doing them, their technique is correct, and it's quite difficult to do that over Teams in a group situation without everybody hearing, whereas in a class you could probably go up to a patient and just give them a little bit of individual feedback. So it didn't work brilliantly. That was the feedback we were getting, and obviously a big limitation for those patients with low IT skills and access. So for those, our cohort or population is probably 60 to 65 plus, so maybe some of those didn't have brilliant IT skills, so getting them to sign up in the first place to a digital Teams exercise program was a pretty tough sell for us in our telephone clinics, if I was honest. Next slide, please. So what we did is we came up with a digital and a hybrid model that was a mixture of traditional and digital, and essentially we let our patients make the choice. So we run the digital model for 4 months, and then we reviewed the data we had, and I'll share some of that data with you next. And we made these decisions to change it to this hybrid model. And also we had to flex a little bit the service with the changes of COVID. At this point, patients were now able to go back into their traditional gym and have exercise as well. And we were able to open up face-to-face consultations for patients with this condition, with an OA knee, which we weren't able to previously. We could only bring them in for an intervention such as an injection previously. So the options have changed for us as well as service managers. So this is the new model we come up with. We wanted to keep the ProMap system. It worked brilliant for us, the PROM system. So that stayed in. So patients were sent the PROMs prior to them turning up for their first appointment. So we had that data, and that system worked well, so we didn't change it. We offered now a choice to patients, rather either telephone assessment or face-to-face assessment. And as you can see, I've included there, the uptake was amazing, really. 95% uptake of patients into face-to-face. So there was a massive demand, user demand amongst patients just to come in and be assessed, and very little demand. So we had to switch our service very quickly from telephone to face-to-face, based on patients making that decision. Now, the last part is we then offered this gym. So the traditional gym model became available again to patients, but we kept the other two options in. We kept the online option because some patients really enjoyed it. And we also kept the self-management option there. So we've now got three options available for our patients. And this is how we are running the service currently as well. Next slide, please. So a little bit of the data that we used to make these decisions, I guess, was around patient decisions. So we've got pathway decisions for patients, and if you look at the digital delivery chart on the left, the self-management is 51%. So 51% of patients originally, when we were delivering this via a telephone consult, decided, you know what, I get what you're saying, but if you send me the information, I'll get on with this myself. I'm not so keen to go on an online weekly course for 8 weeks. 29% of them chose online intervention. So you've got 51% choosing to get on with it on their own. And we knew from the previous pilot that those patients self-managing would get some benefit, but they're not as likely to make behavioural changes without our guidance and supervision and motivation from coming in to have weekly programs. We really wanted to get the online program numbers up higher than 29%. So when we switched to the hybrid model and we brought patients in face to face, well, you've obviously got this purple part of the graph on the right now as well, which represents the gym. So there is another option there. From what happened is patients, if you look at the self-management group, it's actually gone down to 36%, so from 51 to 36%. So our patients were suddenly choosing to take more of an active part, make more of an active decision to change their behaviour. So either choosing to go down the gym program or on the online program. But we were actually getting more patients doing an active intervention then for their condition, which was excellent. I believe there's possibly from having a bit more time with the clinicians and felt that they've had their knee thoroughly assessed and the right decisions were being made for them to go on and do these, and possibly they preferred the idea of going to a gym and doing it with other people because this feels a bit more natural to them than going on to an online Teams intervention, which maybe they're not that comfortable with. Next slide, please. So a little bit of the other data that we used. The graph on the left is just to have a look at what patients were accessing. So this is from the company ProMap. They shared this with us, this feedback, and this is what patients were using to complete their proms. So when we were sending them out these proms via email, it was quite interesting to me to see what technology these patients had. So the majority of them are using an Android and then iPhone or computer really to fill in their proms. Now, this was the bit that caught us out, really, the high numbers of no email patients. So as you can see, we've got two catchments that I cover with this service, and the one catchment with around 16.5% of patients with no email, and then nearly 20% in the other catchment of patients with no email. Now, this did create a bit of a problem for us. Next slide, please. So in the original pathway, these patients were only being telephoned, if you can remember back to the earlier slides, and there was no face-to-face to the majority of them. So there was no capability to back up that prom and collect it in clinic. We had originally planned to have iPads in clinics with patients who hadn't filled it in by the time they come in to a CS. We could then get them filled in the waiting area via an iPad. We didn't have that facility initially on the digital program because they were managed on the phone, the majority of them. So our compliance rate was around just under 72% when we were running it as a digital program. When we switched to the digital and face-to-face, the hybrid version, we've got that up to 90%, and that is simply based on the fact that those that weren't filling them in, those without emails, were coming into our appointments, because I said 95% of them were choosing to come in face-to-face at this point, and still are. We were then able to collect this data with sitting down with them with an iPad in the waiting area. So we've got a prom compliance up by nearly 20% by switching back to the face-to-face model. Next slide, please. So that's where we're at basically at the moment. We're delivering that hybrid model at the moment. what I wanted to do, I'm going to share the data now we've got on the program with you for the last 5 minutes, and what I just wanted to explain before I go through the data is we were asked to get involved in a separate project with this lifestyle program, and we took on, so normally our general group of patients come from GP and their patients were not listed for knee surgery, so they come through us first. If they still are not improved and they wish to have an opinion on knee surgery, then we refer them at the end of our program. At the end of the 8 weeks, we review them and refer them on. That's our normal cohort of patients, and we call these our MCAS group. So they're in the blue set of data, and you'll see that next. Now, we took on 100 patients from the Swansea Bay trauma and orthopedic waiting list. These are patients that have been sat on the waiting list for knee replacement for 18 months plus, and we put them through this ELP project, this diet, education and exercise project or program, to see the effect it might have on them. And that's the data that I'll be showing and comparing and presenting back to you in the next couple of slides, really. So out of the 100, instantly 40% of them declined a place on this. We've got data on about 50 patients, basically. The main reason was they felt they were in too much pain. Next slide, please. So just a bit of an update on where we're at with our compliance. So we're around 88% at baseline, and we've got about 76% of the data back at 12 weeks and only 52% at 6 months. I just wanted to share that with you first because we've got pretty high numbers at baseline and 12 weeks, but it's a new service. We haven't had that many patients complete the 6-month period yet. We only started in April this year, so we haven't got as many numbers through at that point. So just bear that in mind when I'm sharing these statistics with you. Next slide, please. So this is the overall data, and you don't need to look too much into the scores because I'll go through them a little bit more detail on the next few slides. But the main difference is the top block there is in blue. There's a blue box around it. That's the MCAS. That's our traditional group of patients not listed for knee surgery. Average age of these is 59. And then you got the orange square box, the T&O patients who are on the waiting list for knee surgery. Average age is 65. And I'll go through some of the main changes we've seen between the two groups. Next slide, please. So the first one, again, top block, just to remind you, is those that are not listed for knee surgery yet. Orange square is those that are on the waiting list for knee surgery. So this is weight loss. So on average, our MCAS group lost 2 kilograms, and the online, if you have a look at it, was the most effective. So 2.5 kilogram weight loss on the online compared to 1.8 on self-management. There's not much data on that gym group yet. There's only probably 15 patients that have come through on the gym, whereas we may have got around 100, 150 on then online and self-managed through. So the data is low on the gym at the moment, so I'd expect that to maybe change as things move on. But the main finding here is both groups lost weight. The guys waiting for surgery lost 2.6 kilograms, and again, mirrored in the above group is the online group did really well. They lost 3 kilograms. So it does show that our online intervention was working. Both groups losing significant amounts of weight. Next slide, please. So top group here is this is the Oxford knee score, a primary knee outcome. So as some of you might be aware, higher Oxford knee score means the patient has got an improving status. So the blue line, the top group, is our traditional patients not on a waiting list for surgery. The navy line is those that are waiting for surgery on the waiting list. So our top group had score 22, raised up to 25, which is brilliant. There's an improvement in their score, and then it's plateaued off at 6 months a little bit, but not dropped too much. So they've still improving. The T&O group, those that are waiting knee surgery, improved a little. Just 1, it's not a significant change, but then soon as the intervention finished at 12 weeks, they've gone back below their baseline score, and that's represented in the colour charts below as well. So the more green you see, the better status the patient has. So you can see in the MCAS group on the top colour chart, there's 19.8% at baseline, and then that increases and increases as it comes down. So that's just looking at one component of the Oxford knee score, so how much pain they're in on stairs. So the more green you see, the improved status of the patient. When you look at the T&O group below, that's a reduction from 23% as time goes on to 15%. So they're in more pain with their symptoms basically as time goes on. So there's a distinguished difference between the two groups. Next slide, please. AIC score is generated from their Oxford knee, and this is something new we're looking at. This is out of Oxford University actually, and I'm working closely with one of the professors that's come up with this score. And there's basically the higher score they've got, the more likely the patients are to need a knee replacement. So what we found was the MCAS group, those that are referred in to avoid surgery or to try and prevent surgery, we reduced their score by 7, which is a significant reduction. So the less that, reducing your score means you're less likely to benefit from a knee replacement. Whereas those sat on the knee replacement list, we didn't really change much. We changed their score by 1. So again, another big difference between the two groups. Next slide, please. MSK Health, 10% improvement in the T&O group and a 20% reduction in the T&O group. So sorry, MCAS group improved 10%. T&O group reduced by 20%. So similar theme again. So the patients that are actually waiting for their knee replacement surgery are not improving as much when it comes to their pain and disability. But they are, if you look at that dark navy line, they are maintaining their status during the program, during the intervention, but they're not continuing to maintain it afterwards. Next slide, please. So just in summary, the main things I've learned is digitalising a clinical service requires lots of thought and planning. You need to break up your service and have a look at which bits are suitable. And it needs a lot of thought. Theoretically, it is all possible, but the reality of it is quite different. There's lots of pros and cons to it, but that is probably unique to your service, your program, an area you're working on, and possibly unique to your health board. You need to look at your patient populations, your demographics, the IT literacy, capability, age, and see is it suitable to put this pathway online. PROM systems can work well remotely, so without bringing patients in, and with pretty good compliance, we found out. But you do need to plan for those patients who don't have an email that might be higher than you think. So our overall findings suggest that a lifestyle intervention put online can improve patients' weight loss, function and pain. As I've said, the top group that I've shared the details with you have all improved, and we're really pleased with that. That is basically on data from our digitalised service. Our intervention was online predominantly when we captured all that data. In terms of where we're going in the future, well, I think that's probably again going to be shaped by our patients, our main stakeholders in the service. There's demand for them to want to come in for face-to-face, and we've changed and adjusted the service around that. And I think we'll continue to change the service based around what patients want, really, and the data we're getting back from our systems as well. And that's it for me. I think there's a Q&A session now, so if anyone's got any questions, I think Amanda will take over that. Thank you.
Okay, and thanks, Chris, that very informative description of the ELP service, and I'll go straight into some questions. Now, there has been a lot of interest in some of the remarks you've been making about emails. A couple of the queries have been answered around what percentage didn't have an email address, and that there was a comment around, did you approach Digital Communities Wales to help address with the no email problem? So taking those things in mind, what do you feel is maybe the solution to the no email? So were you relying, for instance, on the email in the local PAS system, or were you asking patients for the email address themselves, and did that make a difference? And how do you feel maybe other communication methods could help? So is there a possibility of embedding with text remind, etc.?
Yeah, I mean, this is work ongoing for us, really.
Oh, and we've seemed to have just lost Chris for a moment. If you could all just bear with us for 2 moments, we are going to try and get him back. So please just bear with us. And I think we just got Chris just rejoining us. Thank you, Chris. Are you back with us?
Apologies,
can we just
it
check?
Dropped out then. Yeah. Can you hear me?
No problem at all. Yeah, the question
Excellent.
was around emails and your thoughts around that.
So yeah, this is work ongoing from myself and the team really, and we are looking at different solutions to this and working closely with the technology company ProMap. There's a couple of potential solutions out there and things we've put in place in the interim, I guess, to keep things ticking over and keep that compliance as high as we can. So just to give you an idea of how we collect them, we do actually collect them from the patient in person. We don't rely on hospital systems because the number of patients with emails on the hospital system is extremely low and they are pretty unreliable. They've been on there a long time and most patients will find that or feedback to you that they need updating. So we take them from the patients and we also ask if you've got any friends or family that could support you through that. So we can accept an email so you can fill in some health questionnaires for your up and coming appointment. So we look at all the options, not just the patients having an email. We look at immediate friends and family around them as well to try and capture that data. If they do not have it, as I said, at the moment, we can get that done at the baseline touch point for PROMs when they come into clinic. But the 12 weeks there now is a virtual follow-up has been built into our program and we haven't got the capacity to bring the patients back in to clinic at the 12-week point. So we have to manage that digitally. And at the moment, we're getting those no email patients, which vary from 15 to 20%. We have got the capability of some assistance within our program to chase up those patients on the telephone and get them captured on the telephone. And that isn't an ideal solution moving forward, but it's managing to up our compliance rate by getting a telephone consult from an assistant in the clinic, an admin person to chase those 15% really for their PROMs at the 12-week touch point. We are working closely, as I said, with ProMap to look at a solution around a lot of these patients. What we found do have smartphones. It's just they don't have an email. So we are looking at a shortened version of our PROMs to work via smartphone links. And that's work ongoing really, but I'm definitely open for ideas if anyone's got better solutions to try and target these patients digitally and collect their PROMs, because it is a challenge and it's a higher number of patients than I would have anticipated before starting this program and going down this digital pathway with the program.
Okay, thanks, Chris. And there's a link in the chat with regards to digital communities. So obviously we can share that with you and there could be some more information on that. So staying with the platform for a second, there's obviously some good analytics that is available from the platform and you've showed us some of that today. And then there's a question there around are the data collected in ProMap available to access from other applications, so from Welsh Clinical Portal, for example, or is it locked into that specific application?
No, it doesn't share the data with any other system in the health board, and that's part of the IG agreement as well at the moment, that it's locked into the system and available to extract the data as you wish it to be, but it doesn't share automatically the data with any other health board systems, no. So you'd need your own registry to look at that data, or you can put some agreements in place that data is shared with specific people in the health board, i.e. the value-based health team, analytical team that are receiving the data and helping me put together all the charts and data feedback into some sort of making sense of the data, because it does give you back a lot of data when you're sending out 5, 6, 7 pieces of PROMs and CROMs we're collecting from patients at 4 touch points, so you end up with a lot of data.
Okay, thank you. And staying with the system then, was the ProMap already available to use within your health board? And if not, how long did it take to authorise its use?
That's a really good question. Actually, no is the quick answer to that. It was available in another health board. Powys had trialled it for something else. and I'd had a demo with the team prior when I was at the point of looking for a solution, and it just seemed to fit with what I wanted. It had that capability to store some education content, and a lot of flexibility around it being able to be remodeled to fit your service, with some of the other systems seem a bit more rigid. So we had a free trial, and we were very fortunate to have a free trial to cover the first year of ELP, which is 1,000 patients we've had funding for. And then we'll have to go into negotiations with how we maybe look at funding that ongoing if we choose to stick with that system. It took a lot of work from a cybersecurity, information governance, and a couple of the other departments within the health board to make sure everybody was happy, and before it was signed off. I think moving forward for other services looking to use it, they may not come up against that within Swansea Bay Health Board, but if you're sat in another health board thinking of using it and it hasn't been used, it does take a lot of governance issues to to make sure it's safe to use within your health board.
Okay, thanks, Chris. So changing slightly to, did you explore allowing patients to take their own blood pressure at home rather than coming in for that reason only?
Yes. Yes, we did, and as a team we spoke about this in depth. That was one of the solutions that was put forward. It then comes up to a situation with what you do with those patients that haven't got their own equipment. So you still have to cater for them. So not everybody's got their own blood pressure monitor machine. Our exercise specialists that deliver the exercise really want an updated blood pressure reading. So they don't want something from a GP that might have been on their records for 6 months plus. They want something relatively live within a couple of weeks from when they start their exercise session. So we did consider it, and I'm not saying we wouldn't look at that again, but we just thought, how do we manage that patient that hasn't got any blood pressure monitoring equipment at home in that situation, and the reliability of it with some patients possibly as well.
Okay, thank you. And there's a question here around the difference of PROMs for those self-managing compared to those online or face-to-face over time. Was there a difference?
Yes, I guess that's referring to which intervention performed best. Across the board, the online is, we had an average, if you look at our MCAS group, we had an average of 2.6 kilogram weight loss, a 10% improvement in the MSK Health, and 20% in Oxford Knee, and a 7 reduction score in ache. So the online intervention performed much better than the self-managed program, but both of them have shown improvements. Now, what I don't have masses of data on, and I haven't been able to share at the moment, but I'm very interested in moving forward, is the gym group. So now we've moved back since August. We've got our patients going through the gym, which is the more powerful intervention we feel, because we've piloted it in the past and had excellent outcomes from it. So I'm really looking forward to getting some data from the gym group. But so far, the online group has shown that it does work, and you can get good changes in patients' weight reduction and improve outcomes via delivering on an online pathway, and superior to self-management.
Okay, thanks, Chris. And we've only got a minute left. I just wanted to come to one last question, which I think is probably quite relevant at the moment in the time of very long waiting lists. So do you think the difference in the outcomes is that MCAS is early intervention, so it's a bit too late for T&O patients on the waiting list? And then in thinking about that, is there a call to have this service for T&O patients, I suppose, on waiting list, because you said they did go back to deterioration? Is it something those patients need to keep up? How do you see that lifestyle program working for those patients? Yeah,
well, this is where we're at with it at the moment. All this data has got to be used, and I think this is looked at a national level as well. And this is a big question at government level, where is this potential investment best spent, I guess. And there's two parts to the ELP, the lifestyle program. There's a preventative arm to it. So if you catch people early, we've proven, I think with the data we've got already, that it does improve patient symptoms and they are less likely to end up being referred into trauma and orthopedics if you put them through such a pathway. But there's also a potential argument that if they still end up getting referred on to a T&O consultant for knee surgery, that they're in a better condition and they're fitter to have their surgery. They're lighter, potentially stronger and less deconditioned, and their general health is better from going through such a lifestyle intervention for 8 weeks. So there's a preventative arm to it, but then also a prehabilitation or prehab from a surgical perspective as well element to it. And I don't really know at the moment, where these conversations are going to go and where we're going to end up to it, but I do feel that it probably has got some benefits of both those group of patients. For those group of patients that want to avoid surgery and manage their condition independently or via an 8-week program and continue. This should really be a stepping stone to their independent journey, really, with maintaining improved body weight and keeping exercising. It's not it's an 8-week intervention, and we encourage them then to take on the mantle on their own independently at that point and monitor them in the background. But it could also be used for prehab as well for those that go on to have knee surgery as well. So the answer, I guess, is we would see it fitting into both those groups, really.
Okay, lovely. And thanks, Chris. And that comes to the end of this session. So thank you very much, Chris, for all that information. I'm sure there's lots there that people can take away. I would like to signpost everybody to a PROMS interoperability session we have on Thursday, and I'm sure one of my colleagues will post the website link in the chat. So through the website, you are able to join more sessions. There's been a lot of talk about PROMS platforms today and that interoperability, so you may find that useful. So thanks again, Chris, and everybody, thanks for joining the session.